Yes. My first name is Manway. My last name is Ng, so there's no vowel. You pretend there's one. I am a pediatric dentist by profession and specialty, and I'm also chief of dentistry at a large children's hospital. And it's really an honor for me to be here to be able to react to everything that's been said. And just like the previous speaker, there are just so many things to react to. And I can just save you a lot of time by saying, yes, I agree with everything that's been said, or just take a few minutes and give you my own perspective about things. I'd like to basically react by wearing two different hats. So, one as a dentist, and you might say, well, why is a dentist sitting here reacting to um, inpatient discharge and then outpatient discharge summaries? I ask myself that same question. But I will react from my role as a dentist. And then secondly, I'll try to give you a reaction from my role working in a children's hospital. So first, as a pediatric dentist, I've been in hospital dentistry now for the past 20 years. And just a little background about just dental care. You may or may not know that some hospitals actually have departments of dentistry and that we provide care in an integrated way, or we try to, with our medical colleagues. So just by way of background, we have a department of pediatric dentistry, and we see about 28,000 patient visits a year. We take about 750 patients to the operating room every year and treat them under general anesthesia. And we provide 24/7 coverage to the emergency department. Uh, Unfortunately, lots of time for patients who come in with infection, tooth pain, facial swelling, cellulitis, trauma to both primary teeth and permanent teeth. And then we provide consultations to patients prior to chemotherapy, stem cell transplant, open heart surgeries, et cetera. You may or may not know, but this is my first time before you, so I wanted to give you a context in terms of where I come from. And so in terms of the world that I come from, the patients who come in to see us in a hospital setting oftentimes are underserved. And so we are a safety net provider for our state. I'm in Massachusetts, as well as for the region, as well as the fact that we have patients who come from all over the country and the world because they're actually getting medical care through our center. And so when the patients are discovered to have dental issues, we get called on to take care of those patients. And so until recently, dentistry has been thought of as a profession that takes care of cavities and maybe gum disease. And more recently, we've recognized that, for example, tooth decay is actually a chronic infectious disease where we know how to prevent and manage the disease. And our profession has been slow, maybe to implement prevention and management protocols. We understand the science around prevention and management, but in quoting others who've said this before, that every system is designed to achieve the results it gets, as a profession, we have been treating our two common diseases as acute conditions instead of as chronic conditions, and thus we have traditionally employed a surgical model of care. And what we know is that prevention and involving patient in that care is much more effective in terms of preventing new disease as well as seeing recurrence of disease. And so at our hospital, we used to have a 9-month wait for our patients to receive their dental treatment under general anesthesia. So 28% of 2 to 5 year olds have tooth decay, and many of them have untreated tooth decay. And you can imagine waiting around 9 months to have a turn in the operating room meant that many of these kids would come back with pain, infection, have to be bumped up at the front of the line, and then we have a whole mess trying to juggle the schedule. At the same time, many of these children, after they receive care in the operating room, would come back with pain and infection, again, because the disease was never addressed as a bacterial infection. We fixed the cavities by putting fillings in and crowns on the teeth, but we never worked with the families to address the etiology of the disease process. So knowing that as an issue, I decided personally that this was unacceptable and said, well, what can we do about this? And looked at the science and realized that we really did already know a lot, and decided to then look at quality improvement as a way to accelerate the adoption of evidence-based practice into care. And so we decided to implement evidence-based protocol and then just restructure our care processes so that the providers really had to focus around treating the disease itself. So lots of education, learning about health literacy, oral health literacy, which I have to claim that I'm not an expert in, but working with others and looking at what they've done, have been able to implement guide tools such as risk assessment, self-management care, and we have also taken from the chronic care model and implemented self-management goals, sheets, information, using pictogram, looking at the language that we use to communicate with patients. And in that way, we've been able to see some successes. So in that way, I'm very intrigued by all the discussion so far and talking about how can we actually improve the tools that we use to give to parents and patients. Discharge summaries are very intriguing to me because here, for the first time, through meaningful use, despite the burden that is placed upon us, it presents an opportunity for us to communicate better with our families and to be able to give them some information that they can take home with them. And so that in terms of meaningful use, we have a lot of work to do. I have to also say one other thing about meaningful use in terms of what it means. We were just talking about burdensome for the clinicians. Dental systems are woefully malaligned with medical systems. The EDR, electronic dental record, is nowhere near what's needed to align with the electronic health record. And so therefore, we are in our hospital working out of multiple systems in order to be able to document the care that we provided, in order to be able to provide information to families and patients as they leave the hospital, as well as to be able to provide that information in the patient portal, which is right now through the electronic health record. So I'm hopeful, I'm optimistic that through these regulatory requirements that will also help us as dental care providers or healthcare providers, as well as our healthcare system as a whole. I'd like to make a few comments about discharge of hospitalization and around discharge of children in particular. And this is from my conversations with Jay Berry and others at our institution. This is not my area of expertise, but we believe that discharge is an opportunity to engage the child, the parents, and team members in an ongoing dialogue to create a proactive plan that will meet the specific needs of the sick children and then keep them healthy after they leave the hospital. While there are standards for adults who have been hospitalized, the equivalent standards for children, I believe, do not exist. And so there is a lot of variability that's already been said within institutions and across regions, and there's inconsistencies, omissions, duplication of care, et cetera. But knowledge of the family's goals as well as the child's health and health need is often lacking, and then communication are often substandard. And all of this contributes to a failed transition from hospitalization and then potentially worsening health after discharge and increases the likelihood of readmission. So discharge really, we talked about having standardized processes, such as having clear information for families and patients when they leave the hospital. But there is another thought that the whole system around the discharge process needs to be more standardized. And having myself have some experience with uh, developing best practices around informed consent within our institution, I think of discharge as a process as akin to obtaining informed consent. So there are three processes that may be considered that needs to be completed before initiating discharge for a hospitalized child. One is the need to specify those goals for discharge. Two is to assess the healthcare needs. And then three is to identify factors that would influence the child's health upon discharge. And so the purpose of these processes is really to screen and identify individual patients for whom a lack of an adequate discharge plan will likely result in unnecessary delay from discharge or impact their health after discharge. And so these are really components that are needed to create a foundation about the knowledge of the child, their family, and healthcare providers, which could result in a more efficiently created and executed discharge plan for the patients. So again, this is somewhat repetitive, but discharge really should begin in advance of the discharge, ideally when the child comes into the hospital. The discharge should involve all members of the care team, as well as all stakeholders. And so by care team, we already mentioned that we've been speaking a lot about physicians, but nurses are really wonderful in terms of getting to know patients and to communicate with families. And there is a need to identify who should be the primary individual to be able to communicate with the family around discharge. The discharge care plan should involve teach back, that is, have the patients and parents have a say in their own words of what that plan is. Literacy is huge, so that the communication needs to be said in the right language, at the right reading level, and in a very culturally appropriate way. It's already been said already, but information technology can be very helpful, but meaningful communication and interaction perhaps may be even more important. Um, there, I think, also needs to be a recognition of the digital divide. So where I come from in our department, 70% of our patients are either Medicaid or self-insured. And while we're spending a lot of time and energy trying to create technology and a patient portal, we also recognize that many of the patients will not even log into the system. And so there needs to be some recognition of this digital divide. Standardized processes and clarity around contingency planning. Okay. Families should be engaged and involved in their planning, I already mentioned. And so a lot of it, as I said, is really about processes. I think that clinicians agree with what best practices are. And again, the devil is in the detail. But what we've been trying to do at Boston Children's Hospital is to create some systems changes so that we can get the care team in thinking and changing our workflow around discharge and best practice. So we are creating and testing a checklist for the providers around discharge. Just like we would with a timeout process, getting informed consent, we're trying to create elements of what those best practices are and ensuring that the team actually hits every point. But this is just a start. And so I think as a last word, it's about making information and the way that we communicate that information to patients and families in a meaningful way as much as possible. So I have hope for meaningful use. Thank you very much.